Welcome to the Cases podcast. Today I have Dr. Raz Perera and Dr. Ben Stone, who are going to talk about the Hepatitis C Elimination programme and what we can do in primary care. Raz is a GP and also the Hep C clinical champion for primary care, and Ben is an infectious diseases consultant at the Hallamshire and the lead for is it Yorkshire?
South Yorkshire, North Derbyshire, and Bassetlaw.
Great. I always get lost. Lead for the Hepatitis C Elimination programme. And I was just saying earlier how that whole idea of eliminating hepatitis C blows my mind rather. So over to you guys.
Okay, so today we're going to be talking all things hepatitis C and the elimination programme. I don't know, Ben, if you could just start off by introducing people to the elimination programme and what the work that's been done so far is.
So the elimination programme was established in England in 2018 after a WHO World Health Organization elimination programme for viral hepatitis in 2016. That was established with an aim of eliminating hepatitis C, viral hepatitis more broadly, hepatitis C and B, as public health problems by 2030. The reason that elimination became possible was because of a revolution in hepatitis C treatments. You may recall that the treatment historically was either 24 weeks or 48 weeks of pegylated interferon injections every week and ribavirin tablets with multiple side effects, some people not being able to have treatment because of mental health kind of problems that were contradictory, and the cure rates were quite low. For genotype 1, the commonest genotype in the UK, was only 30%. Some people didn't complete treatment. But in 2015, we had access for the first time to a new class of drugs for hepatitis C. They're called directly acting antivirals, or DAAs for short. These are tablets, drugs combined together, co-formulated into single tablets that act directly on the virus and have very high cure rates of at least 95% in those able to complete an 8 or 12-week course of tablet-based treatment with minimal side effects. So suddenly we have a cure for Hep C that most people can take without any problems, and therefore elimination became something achievable. Hence the WHO and NHS England kind of programs being set up.
Okay, wow. So that's really transformed the treatment. I guess, what are the benefits of treating patients? What are the benefits for the patient and for primary care as a whole?
Yeah, I mean, as you probably already know, hepatitis C doesn't necessarily cause any symptoms, or if it does cause symptoms, that can be quite non-specific, tiredness, other non-specific symptoms. But hepatitis C over many years causes fibrosis of the liver to build up into cirrhosis just from hepatitis C related liver inflammation, which you might pick up with a kind of abnormal ALT blood test, although sometimes blood tests can be normal. If you get cirrhosis, then you're at risk of a lifelong risk of hepatocellular carcinoma, HCC, so liver cancer, or at risk of developing liver failure or other complications of liver disease like variceal bleeding. So there's a kind of importance of finding people who have hepatitis C to offer them treatment to halt any liver disease progression and reduce their onward or lifetime risk of developing liver complications downstream. But also by curing people of hepatitis C, it means they can't transmit it to other people. So their sexual partner or other kind of close contacts. I mean, a lot of people with Hep C may historically have been people who have injected drugs in the past or currently inject drugs. So kind of not being able to transmit to injecting partners if you're sharing paraphernalia is quite important. And kind of treatment as prevention of transmission is key to the elimination program.
Okay, so I guess treat the less burden on referrals, having to give drugs, and reducing the risk of having to do things like liver transplants as well, really. So that's important. I understand the elimination program's been running for a few years now, and there's already been some good work in things like prison settings and the drug and alcohol services. Can you tell me a bit about that within Sheffield and what the achievements of that have been so far?
Yeah, it's kind of been working on hepatitis C for about a decade with a formal program since 2018. That's when the DAAs came into play. ODNs, operational delivery networks, were established across England. We were the South Yorkshire, Bassetlaw, North Derbyshire ODN, and the key for that was ensuring equitable access to and delivery of the directly acting antivirals across the region. So anyone who needed to access those drugs were able to. And over the last decade, we've treated over 4,100 people in South Yorkshire, nationally more than 100,000 people, and cured over 90% of people that we have data for in South Yorkshire. That's been done largely through working in drug treatment services, in prisons, within reach kind of services, outreach services in testing and treatment in the homeless community, rough sleeper population. So really focusing on those with the highest risk of hepatitis C historically, people who inject drugs or have injected drugs recently, and those at highest risk of transmitting to other people. And that's been done in partnership with the Hepatitis C Trust. So people with lived experience of hepatitis C working together with clinicians, mostly nurses, delivering assessment and treatment in the community, but with the hepatitis C peers doing a lot of the testing and supporting people with engagement with assessment and treatment to ensure completion of treatment and cure.
Okay, and so these are, I guess, a lot of these services are more specialist services that some of those patients accessing those services might not necessarily be presenting at general practice, but I understand there's now been more shift to involve GP champions like myself to promote testing within general practice. So where does that come into play, and who are the patients that might get missed from those services?
Yeah, so as I said, we focused on people with an injecting drug use kind of history, kind of risk factor. We know from UK HSA data that the number of people living with hepatitis C in the UK is more than halved in the last decade, down to about 60,000 people now. And we also know that perhaps only a quarter of those are current or recent injecting drug users, and 75% have a more historic risk factor, so no current risk factor, so won't necessarily be accessing drug treatment services, but maybe just living at home, living their normal life, not knowing that they've got hepatitis C, and because they're probably going to be older, they might have a higher risk of having liver disease and being at risk of cirrhosis and other complications that we've mentioned, like liver cancer. These people may not be accessing drug services, but as they're growing older, getting other health problems, maybe accessing their GP or ED or secondary care for other health problems. So there's an opportunity in ED and primary care and secondary care to test those at risk and to link them into assessment and treatment. So hopefully prevent them getting liver complications and also reducing transmission to sexual partners, for example.
It's making me sort of immediately think about, when we're talking to patients about mental health problems and we're asking them about current or previous recreational drug use, and being mindful of when patients have mentioned, they did this something 20, 30 years ago, we might not think proactively, do they need testing for Hep C? But yeah, that's an example, it really is, isn't it?
Yeah.
And I understand there's also certain sort of ethnic groups that the prevalence is much higher. Can you tell me a bit more about which areas to look for?
Yeah, so I guess the key risk factors, other than people who have injected drug use, which could, as you said, be many years ago, could have only been once. These people might be in their 60s, 70s, maybe 80s now, living with hepatitis C. But in terms of other risk factors, kind of iatrogenic transmission, so medical, dental, surgical treatment, nowadays generally abroad, because that doesn't happen, shouldn't be happening now in the NHS. Although I met someone yesterday who'd acquired Hep C in 2007 in the UK, which is a surprise to me. People, particularly from high or intermediate prevalence countries, notably Pakistan, which is now the country with the highest prevalence of hepatitis C in the world. It used to be Egypt, but that's coming down now with a very successful elimination program in Egypt, and Eastern Europe, so previous kind of Soviet bloc countries, Poland and eastwards. So we do find a higher prevalence of hepatitis C in migrants from those countries who come to the UK. So it's important to, for example, at new entrant registration, or new registration with a GP, to ask about country of origin and think about hepatitis C, but probably also hepatitis B, HIV testing in people from high-risk countries. And perhaps to ask, have you ever injected drugs, even if it was only once and a long time ago? Have you ever had a test? It's probably important to test those people too. And I guess the other key risk factor, again, that's historic, is people that receive blood products or blood transfusions in the UK before we screened for hepatitis C. We started screening in about 1990, 1991 in the UK, but the recent infected blood inquiry has said that we should expand that to people that received blood or blood products before 1996 and consider those as being at risk. So that's another important question to ask.
Okay, so lots of different sort of considerations there. And I understand that the GP clinical champions were brought in really to expand that work out into primary care. And we know, we talked about new patient registrations, talking about patients with historical risk and patients that might have had procedures or medical treatment or dental treatment abroad. I understand there's also a patient search identification tool that's been used. How does that work sort of pragmatically?
Yeah, so some of these risk factors that I've mentioned have been built into a search tool, so you can apply those risk factors to a GP practice list of patients, and then it will pick up any codes that identify people at being at risk and then flag them as requiring a hepatitis test if they've not previously been tested before. The other part of that work is identifying those that do have a hepatitis C code, and then we can also check that anyone that has a hepatitis C code has actually been referred, assessed and treated. So we pick up anyone that may not have been referred. Hopefully by now most people with a hepatitis C code have been referred and treated, and largely we're seeing people that haven't got an up-to-date code where we've changed that to hepatitis C resolved, having been cured. But there is a risk that there's some people there that haven't been referred. So really it's just to try and do that case finding and make sure no one's been left behind.
Yeah, so we know coding in general practice can be a bit of a Wild West. So getting that data cleared up is really important. With the search identification tool, so we can run these tools across either System 1 or EMIS, and it finds these high-risk patients. Following that, how are these patients how can they be contacted, and how are they subsequently treated?
Yeah, so we're kind of following the examples of other practices and ODNs that have been working with primary care over the last few years, and we want to make sure that the onus of work on primary care is as little as possible, accepting that primary care is incredibly busy and not able to take on extra work. So we can make it as simple as possible. NHS England are still funding a national web portal, so patients are able to register online and order a home testing kit for hepatitis C. They get sent a capillary blood sampling kit. They take a capillary blood sample, put it in a little tube, send it to a lab, and they get a Hep C result for the Hep C antibody and RNA test to see if they've got hepatitis C infection or not. And those that have infection would then get referred to the ODN, and we would offer treatment. So really the main onus on primary care is to be able to just run the search tool, which itself isn't that onerous. And once that's been done, an automatic text can be sent to patients, and then everything else is done nationally and by the ODN.
Yeah, that's incredible, and I think the ease of that process makes it easier for practices, but also it's a testing process where we're dealing with a patient population here that are, a lot of them may not want to come to testing services or want to come to the general practice. So being able to test it at home with a web portal is actually a really handy way to test. Sorry, I'm just having a quick think about the next question.
It's okay, you're doing brilliantly so far. It's really interesting.
Yeah. I'm just thinking, it was a. Sorry, I've frozen a bit.
We didn't talk about ED much.
Okay. Oh yeah.
I don't know if you want to talk about ED.
Yeah, we can talk about. So alongside that, I understand there's also testing within the emergency department now. So what does that look like?
Yeah. So since 2023, 36 A&Es initially in the UK were identified for ED BBV opt-out testing. So BBV, bloodborne virus, HIV, hepatitis B, hepatitis C. Opt-out testing, meaning a patient attends ED, they're having a blood test anyway. So they get an extra blood tube just sent automatically, and that gets sent for BBV testing. They have to opt out, so it's done unless they say that they don't want that to happen. And there's communication on posters and things in ED that make patients aware that is the process and what's going to happen. So 2.8 million people have had BBV testing since 2023 nationally, and of those, 1,800 new Hep C cases diagnosed, more than 5,000 hepatitis B, so a lot more hepatitis B found. And then don't have the HIV figures actually. In Sheffield, we were one of the second wave of sites, so another 46 sites funded, announced 2023, and we started October of 2024. So we've been going for 9 months. It's been done at the Northern General Hospital, ED. We've tested 30,000 patients. 1 in 70 people attending have Hep C antibody, which is, I think, quite an amazingly high number of people having been exposed to hepatitis C attending ED. But the good news is that less than 1 in 1,000 have hepatitis C ongoing infection, so RNA positive. So I guess that's kind of a testament to the work of the last 10 years. We've already treated and cured more than 92% of people exposed to hepatitis C attending ED. We've obviously still got the 8% left. We found 21 new cases of hepatitis C in 9 months. And when we look at those patients, more than 50% do not have an injecting drug user history. And of those that did, mostly it's a past injecting drug user history, only 2 current injecting drug users. And of those without an injecting drug user history, the main risk factor is coming from a country of high or intermediate prevalence for Hep C, where they would have been exposed through medical, dental or surgical treatment. And Pakistan and Eastern Europe are there as countries of risk and in those patients. So I guess it just highlights what we've already discussed in terms of who are the people left to find with hepatitis C, what are their risk groups and who we should be targeting, not just in ED, but secondary care and primary care more generally.
And going forward, if elimination is achieved by the WHO goal in 2030, how does sustained elimination look? What does that look like, and how is that going to be achieved?
That's a good question, because funding nationally isn't going to be forever. So we know that there's a percentage of people living with hepatitis C that we need to diagnose and treat for elimination to be sustainable. So there aren't enough people living with hepatitis C left in the general population to transmit it to cause a kind of surge in new cases. So it's kind of aiming for 90% diagnosed and 80% treated. And it's quite hard to collect that data nationally and locally. I mean, in South Yorkshire, I said we've treated more than 4,100. We're left with 70 people we know of with Hep C RNA positivity. What we don't know is who we don't know. And there could be at least twice as many, if not more, left to find. I mean, nationally, down to now less than 60,000 people living with Hep C, maybe up to 40,000 maximum left to find. It's still quite a big number with 5 years left to go. We're not going to find everybody, but I guess the key is we try and find as many as we can. Because we've already treated a lot of the people that are highest risk for transmitting Hep C and people that are currently injecting drugs, we probably will achieve elimination. We won't get so many new cases. The biggest worry is that there's people that aren't necessarily going to transmit and contribute to a new epidemic of Hep C, but they're living with a kind of ticking time bomb of liver cancer. And we could prevent that by treating them earlier before they develop that, or at least identifying that they've got cirrhosis and putting them into liver cancer screening with 6-monthly ultrasounds. We know that liver cancers are still rising in the UK. It's the kind of fastest growing rates of cancer of any other site compared to other sites. But there have been really good progress with the Hep C program nationally. We've seen a kind of more than 37% reduction in Hep C related deaths in the last 10 years, now down to less than 2 per 100,000 per year. There's been a massive reduction in liver transplantation, so more than 52% reduction in liver transplants due to Hep C. These are all future cost savings for the NHS that we can spend on other things. So it's really worthwhile, not just for the patient and their relatives and their families, but also for healthcare in general. I guess it really epitomises the kind of new themes from the Department of Health for prevention more than treatment, as well as kind of shifting care away from hospitals into the community. So the Hep C elimination programme really champions those things and is a trailblazer for the rest of the NHS with that respect.
I think it sometimes feels rare that we get really positive stories of success in the NHS, but this is a really good example. And as you said, also aligning to the upcoming 10-year plan, but also it's a great example of primary and secondary care working together to achieve something. So no, thank you for all those insights, and I hope that's helped raise the profile and helped other GPs think a little bit more about hepatitis C.
Thank you.
Thank you. Well, thank you both very much. I certainly learnt loads, and it's definitely things to think about, particularly the new patient registration and people joining from other cultures and countries. That's really useful to know. Thank you both very much.